Hello, friends. So today I'll be talking on this topic, emerging mycosis. So this talk I gave in Hyderabad on 30th of September in Citizens Hospital as part of mycology meet. So I wish to acknowledge my colleague, Dr. Pradeep, who helped me develop this content. So the topics that I would be covering in this topic over next 20 to 25 minutes is the classification of fungi. So I'm sure most listeners would be aware there's a lot of new development that's happening and emphasis being put on the fungi as one of the important source of infection in ICU. At this point of time, it constitutes a fourth commonest cause of nosocomial infections in ICU. And now with the new emerging fungi, it is very prudent that we understand how we approach the fungi and what are the different types that are prevailing. So gone are the days where we talk only about Candida because there are a lot of newer fungi that is evolving and we need to have some understanding as to how we classify these fungi. So maybe I'll spend a couple of minutes on this classification. So just talk a bit on the background and the Candidemia. We obviously we cannot complete the topic of fungal infections without talking about Candidemia. And I'm sure all of you are aware that the Candida auris, which is the new kid on the block, is something which is causing a problem. So we'll talk about Candidemia with some certain reference to what is happening in our country and even globally. So we'll talk very briefly on epidemiology and risk factors. So there's a separate video on whole Candidemia. So, but I'll touch briefly on certain aspects of Candidemia, which is the prudent for intensivists. So the new emerging new fungi which we'll talk and which possibly we pay little attention is the new fungi that are evolving. So we'll talk about Emergomycosis, which is a new fungi which is spreading in the world. Then we'll talk about Histoplasma. We'll talk about Candida auris because that we have to pay little attention to auris. Then we'll talk about Fusarium and very briefly on Mycoses. So there's a separate video on that, so I won't dwell too much on Mucor. So Fusarium, we'll talk about Fusarium. Then we'll have a summary on this whole topic. So when you look at fungi as a classification, so this is very important for all the trainees. So broadly, it is divided into two major categories. One is the yeast and one is the molds. So for our rough understanding, 80% of the fungi in ICU are caused by yeast, which is Candida, and 20% are caused by molds. And the commonest mold that you see in encounter in ICU is Aspergillus. So the other ones which we'll be talking about is obviously the Mucor and the Fusarium, so on and so forth. So in the East, Candida is the most commonest. So I've just put pictures for you to just keep in mind how they all look. So this is Candida albicans, that's how it looks. And Cryptococcus is also comes under yeast. And Cryptococcus we do see occasionally, especially in HIV patients or overtly immunocompromised patients. More so in HIV patients, we see Cryptococcus. It looks something like this. And these are the other yeast which may not be of too much relevance in our ICU because we don't tend to see these very often. So just listed the names. These are the yeast category. In molds, molds is where you have a lot of subdivisions when you talk. So yeast is the simplest one. You have Candida, Cryptococcus, and all this. In molds, it is divided into multiple subdivisions. So it is divided broadly into septate hyphae and aseptate hyphae. So in aseptate hyphae, they come under category of zygomycetes. And in zygomycetes is what your rhizopus and mucor come. So the mucormycosis, which we had a mayhem during COVID, comes under this category of aseptate hyphae, which is mucor and rhizopus, and few others come. So these are the other ones which come. But what is more relevant to our practice is mucor and rhizopus. Septate hyphae is again divided into two domains. Dematiaceous is one domain, and the second one is hyaline molds. But what clinically we see often and we deal is more in the hyaline molds. In hyaline molds, again they are subdivided into septate. In septate hyaline molds is what your aspergillus comes. So this is aspergillus. This is how it looks. And the second one is dermatophyte. You might this is more in a OPD setting. You would have heard of trichophyton or dermatophyton, so on and so forth, causing skin infections. And as the name sounds, dermatophyte, it affects skin. So this is trichophyton, how it looks. So it comes under hyaline modes. But for ICU, what is important is Aspergillus, which is septate hyaline molds. Then you have a dimorphic, which is becoming as an emerging fungi, which is Histoplasma. So it looks something like this. So dimorphic hyaline molds is Histoplasma capsulatum. So these are, so what is relevant to IC is Candida, maybe Cryptococcus, and aseptate hyphae, where relevant is your Mucor, Rhizopus. And then you have the septate, inseptate, Aspergillus comes, and Rhizopus, which I'll be talking briefly, also comes under septate, dermatophyte, and dimorphic, so which is Histoplasma. So just to list the other fungi in Dematius, because I didn't speak about all the fungi because we don't see that very often in clinical practice, which comes under Dematiaceous. So these are the lists. So you can go through it for your theoretical understanding. So what is relevant for us is hyaline molds. Again, re-emphasizing septate, you get Aspergillus, and then you get Fusarium. So dermatophytes is more of skin condition, dimorphic. And in septate, as I said, Aspergillus and Fusarium is more relevant to our clinical practice, which we'll talk briefly. So this is about the classification of fungi. And these are the other names that you can remember in these categories. So just talking about background about fungi. So the fungal disease, it is very pertinent to our historic India, where it is mentioned even in Atharva Veda in 1500 to 500 BC itself, fungal disease is mentioned. And the mention of fungal disease is put as Pada Valmicum or anthill foot. So mycetoma was described. Obviously not as a mycetoma, they called it as infection of the foot, which they called as Pada Valmicum, and which is anthill foot, which is caused by mycetoma. And why fungal disease is important? Because of the chronic disease conditions that we deal with ICU, which is predominantly COPD patients or lung cancer patients. Or India, we have sort of a problem with tuberculosis. So all these make your innate defense mechanism in the lungs to be weakened, and these predispose to the fungal infections within the lung, and so on and so forth. So Histoplasma, which I said is an emerging sort of a fungi, was actually first described in Calcutta. I mean, it was in India. It was described in Calcutta in 1954, and there have been outbreaks of some of these. And in India, mainly the outbreaks that we have witnessed is of Candida auris recently, and of Mycoses during COVID, which all the listeners would be very aware of the problem that we had with Mycoses during COVID. So we'll talk about little about candidiasis burden in India. So just to look at it in a holistic perspective. So in HIV, again, when we talk about Candida, we have to talk in immunocompetent individuals and in immunocompromised. In immunocompromised, we may have to divide them into HIV and possibly non-HIV. So in HIV, basically Candidemia, peritonitis, and esophagitis seems to be more common. And I'm sure most of us who have dealt with HIV on an OPD basis, we see esophageal candidiasis as a common presentation. So 5 to 20% is the sort of a risk of Candida in this population. And it is shown that for every two Candidemia, one of them will be intra-abdominal source. So for every two Candidemia we see in our ICU, one of them can very likely will be the source will be from the abdomen. And recurrent vulvovaginal candidiasis, this is not very pertinent ICU, but it is something that they put an estimate at around 6% as the prevalence of recurrent vulvovaginal candidiasis. And Candida, when we speak from the Indian perspective, it is more common in the non-ICU setting, 4 times more common in non-ICU patients. So, but right now our focus will be more on ICU. But in India, there is no data about the Candidemia load in neutropenic patients. So there is no Indian data as to what is the Candida prevalence in the neutropenic patients, and so is in non-neutropenic patients. So Candida, as I said, can occur in immunocompetent and even in immunosuppressed individuals. So we'll just very briefly look into the global epidemiology and little bit about our Indian data, risk factors. As I said, 80% of the fungal infections in ICU is caused by the yeast, which is Candida and Cryptococcus. 20% rest with your molds, what we call as molds. In molds, it is Aspergillus, Fusarium, and Mucormycosis, which are common. And this is Aspergillus, the way it looks. So this is Aspergillus. And these are the commoner, broad sort of a approach to our fungal infections in ICU. So in ICU patients, when we deal with Candida, the one which we are interested is in Candidemia. So Candidemia is presence of it. When we talk about Candida in ICU, it is either Candidemia or invasive candidiasis. When we say invasive candidiasis, Candida present in the tissues. It can be present in the lung, it can be present in the liver, it can be present in any of the viscera. So Candidemia is what we see very often, presence of Candida species in blood. Why is it important? Because the mortality is very high. If you do not recognize and treat, mortality can go up to 60 to 70%. So when you treat itself, the mortality is around 23%. If you do not treat, it goes up to more than 60%. Okay, these are the references. And as I said, highest mortality is in untreated, where the mortality touches more than 60%. And it accounts for 5 to 15% of the nosocomial infections or healthcare associated infections. And as I already mentioned at the outset, Candidemia is the fourth commonest cause of nosocomial infections in ICU. So these are some of the landmark studies which was done on a global scale, where they have looked at the international prevalence and outcomes of infections. If you see here, the Candidemia was the commonest, and as you see, this is all the data. And in Asia, if you see, the occurrence rate was around 15.7%, and Aspergillus was around 1%. And 62% of the infections globally were caused by gram negative, 47 were gram positive, and the fungi constituted around 20%. Roughly around 16 to 20% is what you can keep, but it is variable. It is quite variable across the continents. In Asia, it was around 15.7% in this global study. So you can keep the rough ballpark of around 15 to 20% as the risk of fungal infections or for the burden of infections in ICU. So even in India, we know predominantly it's gram negative, followed by gram positive, followed by fungal. So this was another landmark study called the EPIC-2 study, which was done in 1,265 ICUs across 76 countries, where they looked at 14,414 patients having Candidemia, 99 sort of a Candidemia, where 69 and 38 were combined. 69 sort of percent had a candidemia, 38 had combined, with the occurrence rate of 6.9 per thousand patient days. So this is all epidemiological data. And when we look at the mortality in the global studies, ICU mortality, as I said, ranges from 25 to around 65% in untreated. In this EPIC study, they showed that ICU mortality was around 42.6. Hospital mortality also similar, and ICU length of stay. As you see, what is striking is the length of stay is very long in patients with Candidemia. So it was around 18 to 44 days, and hospital length of stay was 26 to 60. So basically, the burden of any Candidemia is prolonged length of stay in hospital and in ICU. So again, this slide from studies showing that Candida comes as the fourth commonest cause of nosocomial infection. So let us look very briefly at the Indian data. So as you see, these are different institutes, the SCPGI, AIMS, Gangaram Hospital, and Saptarjung Hospital. So as you see, Candidemia is around 27%, and in India, non-albicans is most prevailing. So 88.5% to around 67% were non-albicans, and Tropicalis is the commonest. So these are the data from AIMS, where Tropicalis constituted 33.5%, Glaberata 17, and mortality, if you see in India, from SGPJ it is 55%, AIMS it is around 72.2%. But as you saw, the global data mortality shows anywhere from 25 to 63% untreated. So it's all the more important we pay attention, because in India mortality seems to be much higher. So again, just to look at from the Indian perspective, we have, as of 2020 data, 94,961 ICU beds at this point of time. And the ICU admissions is 6.51 per thousand patient days. And the occurrence of Candidemia is around 13.6 per 100,000 population. And in India, overall, if you look at the data, Tropicalis constitutes 42%, albicans 21%, and auris, which is an emerging sort of fungi, is 5.3%. And from the Indian data, the median length of stay when they looked at in 124 ICUs was 6 days, which is far lesser than the EPIC study, where we saw a much longer length of stay in hospital and ICU. So this is an interesting data in patients with end-stage renal disease who are on peritoneal dialysis, continuous ambulatory peritoneal. They evaluated 8,500 patients who are on peritoneal dialysis. Peritonitis occurred in 0.39 uh, per patient years, out of which 2.2% were candidemia. So again, in CKD patients who are on peritoneal dialysis, who develop peritonitis, 2.2% of the patients can have candida peritonitis. So this is something, this is a pure Indian data. Just for your reference, you can keep it in mind. So when it comes to risk factors, so candidemia, so what we have understood from Indian perspective is even in India, it is the fourth commonest cause of nosocomial infections. Mortality remains high, and non-albicans is more common, tropicalis is more common, and auris is creating a problem. So that is the sort of summary thoughts that we can have at the end of this. So risk factors, most of you are aware, there's something called Candida score. Any patients, any of the ICU patients, they would have had post-surgical sort of a status. They can have sepsis, and they would have had Candida colonization, and some of them may be on TPN. So all these constitute risk factors for Candida, and based on this, there is a Candida score that is evolved, and there is a score of 1 given for TPN, 1 for surgery, 1 for colonization, and 2 for severe sepsis. And if any score more than 2.5, one should suspect possibility of them having Candida infection. But this is a very important slide to say these are the common risk factors for Candida, and any ICU patients that you would be dealing with would have one of these components which will put them at a risk of developing Candida. And so CVC catheter carries an odds ratio of 9.5. So that is very high risk of them developing candidemia just, just because of a CVC catheter sitting in. The next comes stress ulcer prophylaxis. And the fact they're in ICU itself constitutes a odds ratio of 6.4. And someone having nasogastric tube is a risk factor, odds ratio of 3.7 in having candida. And use of indiscriminate antibiotic usage also portends a risk, and higher Apache score, the more sicker the patient, higher is the risk of candidemia. And someone who's had a laparotomy, renal failure, anastomotic leak, so on and so forth. So if you look at this picture, any ICU patient would have any of this, would have Rayleigh tube, they may have some CVC line, and they are sick, or Apache score would be high. And use of PPIs also is a risk factor for candidemia, and AKI is a common sort of a thing, and most of your ICU patients would be on some antibiotics. So if you see all in all, any patient sitting in ICU for some period of time has enormous number of risks that would put them at having candidemia or candida infection. So now we'll move to, so all this what I spoke, I'm sure many of you would have heard in various other lectures, and you would be already aware of candidemia because we know pretty much about it. We'll talk about newer fungi. So Emergomycosis is the new one. Histoplasma is the second one. And we'll talk a bit on Fusarium and Candida auris. So Emergomycosis, it tends to occur in immunocompromised patients. HIV is one area. It can occur in febrile neutropenia or in solid organ transplant, or an individual who is on immunosuppressive drugs. In India, why is it important? Why are we talking on this? Because in India, there are different types of Emergomyces. The species that is identified in India is Emergomyces pastorianus. So this is the species that is emerging in these immunocompromised patients. So if you look at the global distribution of this Emergomyces, it's very interesting, very easy to remember also if it gets asked in your exam. So if you see this is Canada, so the Emergomyces in Canada is called Emergomyces canadensis. So this is Europe, so the name is very simple, Emergomyces europaeus. In India, I said it is, in India they should have called Indianus, but they have called it as pasturensis, not sure. In Africa, it's called Emergomyces africanus. Only in India it is different. So in China, we know it's a oriental country. It's called Emergomyces orientalis. So in India, it's called Pasteurellus, so for whatever reason. So it's very easy to remember. These are the species distributed globally. And Emergomyces, one gets infected if someone is immunocompromised by inhalational route, and it can be sitting there as a colonizer, and they can manifest with a lot of skin manifestations. So, and when they replicate and they multiply in the yeast-like forms, and skin manifestations is what is evident, or one should raise suspicion if you see skin lesions. It can vary from papules, nodules, varicose ulcers, custard plaques, or erythematous. So if you see, they can be quite striking and quite evident. It's very evidently sort of a manifested skin lesions is what one would witness in emergomyces. Not that I've seen, but these are some of the pictures of emergomyces. So how do we diagnose emergomyces? So it is a challenge. It's a new fungi. So it is a challenge to the microbiologists and to the clinicians. For all my intensive care friends, never ignore skin lesions. If you see evident skin lesions with a systemic manifestations in an immunocompromised, think about some rare sort of a fungi that may be there. And three-fourths of these cases gets misdiagnosed as tuberculosis. So the diagnosis is clinched with histopathological examination and fungal culture. So bone marrow aspirate is something that one can do and identify fungal elements in the bone marrow or lymph node biopsy or BAL. So these are some of the methods to get a histopathological sort of a confirmation of this emergomyces. PCR is the easiest way of ascertaining emergomyces. So PCR panels, if they have ability to look for the gene of this emergomyces, that would be the easiest way for ICU. And bone marrow aspirate is something that is touted. So why we are talking about emergomyces in mycology is because at this point of time there is no guidelines from any society as to the treatment of choice for this emergomyces. But the treatment is liposomal amphotericin B. That is the only drug that works against this 3 to 5 milligram per kg for 1 to 2 weeks. After 2 weeks, it has to be de-escalated to itraconazole for 200 mg 3 times a day for 3 days. So the thing about emergomyces is it cannot be eliminated and sometimes it has to be taken lifelong. So itraconazole for 1 year. So that is the burden of this disease. And if patient is immunocompromised and he cannot be converted to immunocompetent, itraconazole has to be taken for lifelong. So it's a very dreaded fungi. That's why we are talking about it. And it is there in India. So it is Emergomyces pasteurans. So keep an eye on this. So this is something to be looked at in someone who is immunocompromised because every hospital is overzealously doing a lot of transplants and we get a lot of post-transplant patients on immunosuppressive drugs and we have hematological malignancies who are on induction remission therapies. So these are some of the patients where one should have index of suspicion for these exotic fungi. And these are the culture plates, how it looks, emergomyces. So initially it looks like white glabrous sort of a structure. Then later on it gets into this buff, yellowish buff, and then they have a yeast phase. And this is the histopathological sort of a representation as to how the fungi looks. So white glabrous, ochreous buff, and yeast phase. So those are the different phases you see on the culture plates. So that's about emergomyces. Then we'll slowly move to fusarium. So as I said, fusarium comes under septate molds. It comes under the mold category. So it is a plant pathogen. So fusarium comes from the plants. Again, this was identified first in Calcutta in 1958. And fusarium, like emergomyces, spreads through inhalational route or directly through skin inoculation. So all these fungi tend to spread either through respiratory route or through the skin inoculation. Same was the case in emergomyces. So there was a study called Transnet study, which was only done in solid organ transplant and hematological stem cell transplant. And they found that 22% of the mold fungus was caused by fusarium. So non-aspergillus molds, after aspergillus, it was the fusarium which caused most infections in this particular study. So fusarium, what all organs it can affect? It can affect central nervous system. And most of these fungi, I'm talking exotic, tends to affect skin. So fusarium also can be present on the skin. It can affect the lungs. It can affect the liver and reticuloendothelial system, GI system. It can affect the kidneys. And it is angio-invasive. It is like mucormycosis. It can be quite angio-invasive and it can spread through the vessels. And it can be quite debilitating in that sense. And it belongs to similar family of Aspergillus and it can cause keratitis. So these are some of the clinical manifestations of fusarium. So any of the fungi speak, they get seeded into any of the organs once they get into the blood and skin. So skin and viscera is what you should keep in mind of all these new exotic fungi. So clinical manifestations, initially it is known to present fusarium with the skin rash which progresses into nodules, and it can present as an eschar. So eschar in ICU in an immunocompromised is not rickettsia. You have to look at all these exotic fungi. So, so Fusarium, Emergomycosis can start off with the skin manifestations along with systemic manifestations. So in Fusarium, look for an eschar. And like mucor, it presents with sinusitis. Rhino orbital involvement can be there. Rhinosinus involvement can be there. And lung are the commonest sort of regions which get affected by Fusarium. So diagnosis is fungal blood culture. Skin biopsy is the easiest in this. So try to, because you have predominantly skin manifestations early on, skin biopsy can yield the diagnosis. So beta D glucan, which is a cell wall marker for fungi, is non-specific. So galactomannan can be done, can be utilized, but they have cross-reactivity with aspergillus because it belongs to the same family of aspergillus. So galactomannan can will only tell you there can be either this aspergillus or one of these molds, but it may not be very specific. So, like any fungal, PCR or multi-top is other modalities where we need more work in this to utilize these tools to identify these exotic fungi. So what about treatment for Fusarium? It is highly resistant to most antifungals. So all these are molds which are not sensitive to the conventional antifungals. Again, the drug of choice is liposomal amphotericin B, 3 to 5 milligram per kg for 1 to 2 weeks. IV posaconazole is also shown to be effective. Like in mucor, because it involves sinuses, so surgical debridement of tissues or even skin to some extent may be needed. And mortality in Fusarium remains high despite it's like mucor, it remains high. So that's about Fusarium. So we spoke about Fusarium, we spoke about Emergomycosis. We'll talk a bit on Candida auris because this is something which we tend to see. So what are the key markers for trainees? What is the difference of Candida auris compared to other Candida? There are distinctive markers for Candida auris. So auris, the name auris, it was first identified in Japan. It's called auris because it spread. It initially it was identified with the infection afflicting the ear. So the spread happened through the ear. And this auris, like any other candida, is not responsive to any first line azole. So it is all azoles, it is resistant. So candida means you'll start azole, but auris is something which is resistant to all azoles and it can affect the skin. Like unlike other candida, it can affect the skin and it can present with bacteremia like candidemia. So it can present with candidemia, it can present with skin and soft tissue and not responsive to azoles. So when you look at the Candida auris, it is spreading very fast and it is a global burden. So if you see the markings here, the brown ones are the countries where more than 100 cases of auris have been reported. So as you see, India comes in more than 100 cases, the America comes in more than 100, and some of the European nations, including UK, comes to more than 100. The pink one is 99 to 100 cases. Not the pink, this is whatever reddish one. The pink one is less than 10 cases. So this is the global distribution of Candida auris. So again, figuratively, schematically showing what all organs Candida auris affect. It can cause meningitis, it can affect the bones, it can affect the lungs, and it can be, the problem with auris is it can be present as a skin colonizer, which leads to outbreaks of Candidemia in ICU, and it can affect the GI tract, it can affect the renal and pelvic calyceal system. So the problem with Candida auris is it leads to healthcare outbreaks. So diagnosis is like candidemia, you have to do fungal cultures and you can utilize PCR and multi-top to identify this early on. So the treatment of Candida auris, as I said, it is resistant to all azoles. So fluconazole, 100% resistant. Amphotericin B also 25% of them are resistant to amphotericin. So the drug of choice is echinocandins. So even in echinocandins, it is showing resistance. 5% of them are resistant to echinocandins. So Candida auris innately shows resistance to all three domains of antifungal agents, and 70% of them show resistance to at least one of these antifungal drugs. 25% of them show resistance to two of these drugs, and 1% shows resistance to all three. So this is the problem with Candida auris. So we finished the third one, which is auris. Then we'll move to the last one, which is histoplasma. So histoplasma capsulotium, as the name sounds, it has a capsule. It looks something like this. And as this figure shows, this illustration shows, it spreads again through aerosol route. And mainly histoplasma is seen in individuals who are in contact with animals or livestock sort of an environment is where it is common, especially someone dealing with poultry, someone dealing with livestock is where it tends to get affected. Again, the risk factors is HIV patients, solid organ transplant, uncontrolled diabetes, or someone who is on immunosuppressed drugs, like any of these conditions. So this is interesting. Why histoplasma we are talking? Because in India, they have identified regions which are hugely which where the problem is more. As you see, the problem is more in Kerala, Orissa, and Chhattisgarh, followed by Andhra Pradesh, followed by Rajasthan and other states. So, which means it is very much prevalent in India, and the states that are more affected is Orissa, Punjab, Kerala, and Chhattisgarh, followed by Andhra Pradesh, Rajasthan, and few other states. Again, figuratively showing histoplasma. I think it's very easy now to for trainees to answer. All these fungi affect every system. So neurological system, bones, lungs. In lungs, it manifests like TB. It can have a granulomatous sort of a presentation. It can cause cavitation in the lung. And it can be present as a colonizer on the skin. For all the fungi we have seen, Emergomycosis, Fusarium, and even Candida auris and this histoplasma all can be present on the skin. But the manifestation was more profound in Emergomycosis and Fusarium, as we saw. And even this histoplasma can be present in the liver and in the GI tract. So clinical manifestations it can be very vague. They can present with headache. But as I said, histoplasma tends to mimic deep tuberculosis. So they can present with all the lymph nodes. They present with more respiratory symptoms, cough, dyspnea, fever, malaise. And main hallmark is lymphadenopathy, which is a hallmark of histoplasma. Diagnosis is fungal cultures and histopathological examination and fungal cultures, bone marrow spread. Since there is mainly manifestation of lymph node biopsy and BAL also can be helpful. The other interesting is you can histoplasma antigen can be detected in the urine also. So treatment for histoplasma again, no other antifungals work. It's liposomal amphotericin B for 1 to 2 weeks, followed by itraconazole, very similar to emergomyces, 200 mg twice a day. So that's about histoplasma. So we spoke a bit on Candida. We spoke about classification of fungi. Then we spoke about four emerging fungi which are present in India: Emergomyces, Fusarium, Candida auris, and Histoplasma. So the summary slide for us is for all the trainees. So it can yeast fungi. Since the talk is on emerging mycosis, we need to understand the classification. Yeast and molds. Molds constitute roughly around 20% of all the infection burden in healthcare, and 80% of the fungal infection is caused by yeast, and predominantly it is Candida. Candida auris is what, as intensivists, we should keep in mind is problematic, and outbreaks are happening, and effective good infection control practices have to be put in place to curtail the spread and outbreak of this Candida auris. In molds, for intensivists, remember there are septate hyphae and aseptate hyphae. In aseptate hyphae is important because we have dealt with this burden of mucormycosis, which come under category of zygomycetes. In septate hyphae, what we deal is with these two categories, Dematius and hyaline. But what is interesting, what is important for IC is hyaline molds, which is aspergillus, which comes under septate and fusarium. These are the ones which are emerging fungi. And in dimorphic, it is histoplasma, which is causing problem. So these are some of the things that we can at least keep in back of mind when we are dealing with fungal infection. So that's about it. So, and emergomyces is another one, which is a new one. So thank you one and all. So I request everyone to present your valuable work to our Journal of Acute Care, which comes every 3 months. So you can visit my website, www.drpradeeprangappa.com to read to this. So thank you one and all.